Now, what about today? Dr. Douglas A. Perednia is a clinical and research physician in the diagnosis and treatment of skin conditions. He is on the cutting edge of applications of computer imaging in medicine. He is the director of the Advanced Telemedicine Group at Oregon Health Science University and a founding director of the Telemedicine Research Center, TRC, an Oregon-based nonprofit corporation. The TRC's worldwide web-based information exchange is now the most comprehensive source of telemedicare information in the entire world. Oregon Health Science University and the web-based internet provides the home base for worldwide access for the work of Dr. Perednia and his associates. At Oregon Health Science University, he is a medical internist and assistant professor of dermatology and of medical informatics. He is currently the principal investigator on a $2 million National Library of Medicine project evaluating the effectiveness of telemedicine in dermatology. The author of many works, his 1995 paper on telemedicine in the Journal of the American Medical Association has become the most referenced article on the subject in medical literature. The benefits to our city and to our region of this man and his work being focused here at Oregon Health Science University are manifold. To me, they epitomize the underpinnings for our region's economic and social future. They represent another example of the importance of OHSU to Oregon. Thank you, Dr. Perednia, for sharing your vision and your work with us here today.
Thank you very much, Mr. Frisbee, for the introduction. It's a particular pleasure to be here to talk at the City Club today. For years, I've listened to broadcasts of your Friday noon conferences and thought, gosh, I didn't even realize that problem existed. I sure am glad there's somebody working on that. And as a result, being here today is something of a relief. I'm hoping that I can describe the world of telemedicine and then go home and tune in to get all the answers this time next week. The other thing I should mention probably is that I'm a very visually oriented person, as my work suggests, and this is seriously the first time I've ever given a talk without the help of visual slides or aids of any other sort. And it puts me at a little bit of a disadvantage in doing this, so I hope you'll be patient as I take the next 10 minutes to describe what the first slide looks like. Seriously though, there are 4 things I really want to accomplish today. The first thing is to introduce a theoretical basis for thinking about telemedicine. Telemedicine has been subject to a lot of hype, just like virtually anything dealing with telecommunications anymore. And it helps to get an idea of why it exists, what it is, and then what you'd like to do with it. I'd like to identify then some of the implications of what growth in this field may mean to us and others, provide some insight as to where we are today, both in Oregon and elsewhere in this field, and then describe some of the challenges posed by this area of medical endeavor, both actual and potential. Let's start with what is telemedicine in general. Telemedicine, the word, comes from combining the Greek root tele, meaning far off, with medicine. And so thus you have telephone, which is far off voice, which is telegraph, which is far off sound, and television, which is far off vision. And so telemedicine, broadly defined, is the use of telecommunications technologies to provide medical care services remotely, at a distance by use of telephone, televideo, store and forward imaging, that sort of thing. Telemedicine can be used to provide medical care directly through patient monitoring or through medical education. In a practical sense, though, clinical telemedicine really has 4 essential ingredients. The first ingredient is data or information. If you don't have any information to transmit, there's no point in talking about telemedicine because there's nothing to send. The second thing is that you really probably ought to have distance. If you're in the same room with the information that you need to transmit, what's the point? Why bother? The third thing would be some kind of expertise or ability to interpret that data. If you're sending the data to somebody who can't interpret it any better than you can, it's not really telemedicine, it's something else. And then finally, a way to electronically transfer that information. If you don't have the lines or a satellite link or anything else, if you're doing it by postage, that's sort of considered out of the realm. In terms of how this works, I'm really quite astonished that there hasn't been much published about the theory of telemedicine, that people just assume they know what it is and how it works. But if I can give you one thing to go home with today, it would be an idea as to what it is we're trying to do. And if you can remember the next couple minutes, then if you forget everything else, this talk will have been worth it. The first thing I would like to talk about is how we manage disease, how we treat disease, diagnose disease, and that sort of thing. And if you can imagine all the diseases in the world, or all the cases of a single disease, they fall into a spectrum. There are things that are very easy to diagnose and things that are very hard to diagnose. And there are things that are easy to treat and things that are hard to treat. And to give you a specific example, there is a disease in dermatology called malignant melanoma, which is a potentially malignant, potentially fatal, well, it is malignant, but it's potentially fatal cancer of the skin that typically appears as a change in a mole or a new mole that appears. And melanoma covers a wide range of clinical presentations. It can be very easy to diagnose. Typically, if you walk in and see something that's very irregular, has a lot, that looks sort of like a mole but has a large size or irregular pigmentation, you can look at that and say, gee, I'm really worried about a melanoma. And in fact, things that are easy to diagnose, we actually have a name for in medicine, and those are doorway diagnoses. You literally walk in the door, you look at it, and you say, boy, how long have you had that case of whatever it is? On the other side of the curve, and these things sort of make like a bell curve, so there's things on the easy side, things that are on the hard side are what you might want to call autopsy diagnoses. You can't tell until you do an autopsy or do some other kind of test to figure out what it is that's going on. And to give you an example, in the case of melanoma in particular, there was a paper published in 1991 from Columbia Presbyterian Medical Center called Melanoma, I Can't Believe It's a Melanoma. And the entire basis of that paper is that they looked at 178 cases of melanoma that came in to the pathology lab there, and they went back and looked to see what the original diagnoses were. And there was a subset of about 7.4% of those cases in which the clinicians could not believe that it was a melanoma even in retrospect. They looked at it and they said, you know, that's anything but a melanoma. That could be a basal cell skin cancer, it could be a benign growth, it could be a sunspot, but I don't believe it. And that represents the other end of the spectrum. Most things we deal with fall somewhere in between. So there are things that are really easy and things that are really hard. And when you say really easy, what you're really saying is that you require relatively little information to make the diagnosis. When you go to your doctor, and the doctor looks at you and says, I'm not really sure, what's the next thing they do? Well, the next thing they do is they start doing tests, often expensive, invasive tests or laboratory tests, and the reason is because you don't have enough information initially to establish what's going on. So you continue seeking more and more information until the puzzle makes sense. It's the same thing with virtually anything that you go in to be seen for. Set that aside. Now, you've got that concept in mind. Now, set that aside. Let's look at a second concept. And the second concept is that in telecommunications, All telecommunications modalities represent trade-offs between the cost of that communication and the amount of information transmitted per unit time. Now, let me give you an example. Telephones are very inexpensive, but you don't transmit very much information per unit time. What you're trying to do when you use a telephone, particularly to describe something that for medical purposes on the phone, is you're trying to describe something in accurate enough detail that the person on the other end conjures up in their mind an image of what it is that you're looking at. And so if you give enough detail and you say, well, what I'm looking at is a mole that's really irregular and it has a lot of different colors in it and it's awfully big, then someone on the other end of the phone goes, you know, that sounds a lot to me like a melanoma, and I can see what that looks like. The problem with that is that the quality of the description depends a lot on the person providing it. Some people are just terrible at describing things. It has nothing to do with your skill at anything else you might do. And the other thing is it takes a while. And so to come up with a very good description might take minutes or even hours. Still images, which is another form of telecommunications, are more expensive to relay, but they contain more information. After all, a picture is worth 1,000 words. And as you'll probably recall just a couple minutes ago, weren't you really horrified when I said I was going to describe what the first slide looked like? If I just put the slide up there, you wouldn't have worried about it because you'd have said, well, I can stand this for a few seconds. Video images and video relay, two-way interactive television, for example, they relay still more information because after all, when you're looking at video, you're looking at 30 still images every second. So there's 30 times more information than is in a single still image. And they're particularly good at relaying things about motion, information about motion. They're much more expensive to transmit, however. A typical and uncompressed television signal that you might get on your own TV at home contains the same amount of information as could be carried by 1,300 simultaneous telephone calls. So we're talking about orders of magnitude difference in cost and orders of magnitude in terms of differences in information that you get transmitted. We can go even beyond that. There are virtual reality technologies where you create entire worlds by transmitting huge amounts of data that tells you what it looks like above you and below you and behind you all simultaneously. And they require enormous amounts of bandwidth, which is the term for carrying capacity. In fact, some of you might have seen a program on the other night about military telemedicine, where they were doing virtual reality and telerobotic surgery and that sort of thing. And there are a couple lessons from that. One, only the military could afford to try to do things like that. And the second thing is you probably shouldn't believe everything you see on TV. Anyway, if you plot on a graph the cost of a telecommunications technology versus the amount of information per unit time that it delivers, what you have is a graph that starts out pretty low on the left-hand side near the y-axis and then rises probably almost exponentially as you get up towards virtual reality technologies. You transmit a lot more information at a much higher cost. Now let's put these two concepts together, both of these things. The difficulty of diagnosis and the amount of cost and trouble it takes to transmit a lot of information. What it says is that the data transmission capabilities of various types of telecommunications allows you to diagnose or manage some fraction of problems that you might encounter medically, so that the telephone can allow you to do a lot of things. Almost everybody calls the doctor when they're sick, and frequently that thing can be handled over the phone. And what that means is that there's not a lot of information required to deal with a problem. If you call the doctor and say, I've got a sore throat and everybody around me's sick and I'm coughing and that sort of thing, their usual diagnosis is a cold because that information is pretty well sufficient to make the diagnosis of a cold in most cases. Approximately 25% of primary care provider time is actually spent on the telephone, so this is a pretty effective means of communication. Still images are extremely valuable in certain medical applications. Teleradiology is one of them, where virtually everything a radiologist does is looking at still images, and so if you just transmit images, looking at transmitted images is not much different than what a radiologist typically does. And much of dermatology itself is done by looking at slides, especially when you're training for exams and that sort of thing, looking at color atlases. Interactive television can convey most of the important content for many types of mental health disorders or movement disorders. So as you add more and more information, the amount and the scope of the number of problems that you can deal with goes up. And then if you have virtual reality surgery and all that sort of thing, you can handle even more things than you would be able to handle normally. The thing you ought to be asking yourselves right now, because we've got to bring telemedicine into perspective relative to everything else in the world, is where does in-person consultation fit in? And if I were feeling mean, I guess I would ask somebody to answer that question. But really, the answer to that is it depends. That's truly the answer. It depends. Obviously, the amount of information transmitted per unit time in person is very, very high. So when I'm sitting in front of you, I can look at you, I can talk to you, I can feel your skin, I can feel for lumps and that sort of thing. I can listen to your lungs. I can get a lot of information in a very short period of time. But what about the cost? Where does cost come in for in-person consultation? Because remember, that's how telemedicine works. We're comparing information versus cost per unit time. And the answer is, again, it depends. If you're in the same room, the cost is zero or near zero. On the other hand, if you're on the dark side of the moon, the cost is astronomical. Forgive the pun. It's literally millions of dollars, because that's what it's going to cost you to mount a rescue mission to go get somebody into a position on the dark side of the moon to see what that person's problem looks like in person. So where telemedicine fits into all of this is that it's a tool that allows us to expand the reach of the care that we provide to people in areas where providing services in person might normally not be economical. So by use of telecommunications, in some fraction of cases, we can go out and gather enough information to say, gosh, that really looks like a melanoma, or gosh, that person looks like they have a particular movement disorder. And I don't have to either drag them to me or I don't have to go to them. And depending upon how expensive that cost is of seeing them in person, that's what determines how useful telemedicine can be in that particular circumstance. If it's going to be just as expensive to provide the telemedicine service as it is to see the person in person, then why bother? On the other hand, in many situations, particularly in rural areas of this country, in Oregon in particular, in eastern Oregon, the expense of seeing somebody in person can be pretty dramatically high, especially if the weather's bad or a lot of other situations occur. Some examples of that: physicians are poorly distributed in Oregon. 87% of Oregon's physicians live within 15 miles of the I-5 corridor. Only 71% of the state's population lives within 15 miles of the I-5 corridor. And currently, at this time, 92% of Oregon counties either contain or are themselves health personnel shortage areas. So if you're going to get medical personnel to see people in person in those sites, you're going to have to do a lot of driving. Provider retention and recruitment also depends upon supporting people in rural areas, and it gets very lonely being the only person out there. If you can, by means of telecommunications, take some of the burden or stress off people who are in rural areas, you might get higher retention rates, because people very rapidly burn out if you're the only source of medical information or care available. If we can't find a rational way to support those providers, things can get a lot worse. And the last thing is that specialists are even more difficult to support in rural areas because they require large populations to both maintain their skills and keep them sufficiently occupied. Despite the current rush to emphasize primary care practice, specialists are very important because it's virtually impossible for everybody to know everything about medicine. As an example, the average beleaguered medical school graduate, when they get out of school, they've had only 30 hours or less of dermatology training total, even though there are hundreds and hundreds of skin diseases. So the bottom line is that when the cases get harder, specialists can actually save you a lot of time and money. So telemedicine is important because it may allow us to redistribute the resources that we have that are irregularly distributed and distribute them to places where you wouldn't normally have access to them. This whole area is undergoing an enormous period of growth right now. It's just been very, very impressive. To give you an example, there were 4 interactive telemedicine systems in the United States in 1990. In 1994, there were 40, and currently, as of today, the Telemedicine Research Center has data on well over 100 telemedicine programs throughout the United States. They're in 40 states, at least 40 states, and there are probably a lot we don't know about. And if you count teleradiology, which is probably the most common telemedicine application, there are thousands and thousands of teleradiology units in use right now. Federal funding's increased dramatically. There are at least a dozen federal programs, mostly in agencies that are competing with one another to outdo one another to get into telemedicine, that are currently active. One reason they want to get into telemedicine is because telemedicine is a pretty fashionable field for an agency that's trying to justify its existence. Thus, the National Library of Medicine, the Office of Rural Health Policy, the Agency for Healthcare Policy and Research, the Healthcare Financing Administration that funds Medicare, the Rural Utilities Service, are all struggling to provide funding for telemedicine research and demonstrations. And then military spending alone for telemedicine has exceeded well over $100 million since 1990. And the military has reportedly asked for over $1 billion for telemedicine over the next fiscal year. To give you another little sense of perspective, the Army is spending $10 million for telemedicine in Bosnia alone. A number of states have actually invested their own money, or more accurately, their own taxpayers' money, in telemedicine programs to try to get a competitive edge in this field. There are also companies that are investing their own money. For example, there's a company in North Carolina that reads films remotely. They now serve 23 different states. So people transmit them x-rays. And prisons are particularly fertile grounds for expansion of this area, and that's because, again, the cost of seeing somebody in prison or from a prison in person is very, very high. In Texas, which is where a lot of this activity is going on, for two reasons. One, Texas has a ton of prisons. If it were separate, Texas would actually have the largest prison system. If it were a separate country, Texas would have the largest prison system in the free world. This is true. But if you're in a prison in Texas and you're brought outside of that prison to receive medical care, the cost of getting you there is about $1,000 per episode of care. And there are all these rules. There are enormous numbers of rules about transporting prisoners, the security that has to be involved in transporting prisoners. There are things called chain vans, where you actually chain the prisoners to a van. It's Texas law that if those vans break down on a Texas public roadway, that road must be closed until the prisoners are transferred to another van. That could be awfully disruptive and cost a lot of money. And in fact, just this week, two companies in Florida announced an agreement to go ahead and develop nothing but telemedicine systems specialized for the prison market. Why is this happening now is actually a very good question. Because telemedicine, actually the idea and whatnot has been around for at least 30 years. Some people say that telemedicine started when Alexander Graham Bell spilled acid on his pants. And said, "Watson, come here, I need you." But in fact, in practical application, telemedicine has been around for at least 30 years. In 1959, Dr. Albert Jutra in Canada and Dr. Cecil Whitson in Nebraska started dealing with teleradiology and telepsychiatry, respectively, in those two places. But it really hasn't taken off. There have been starts and stops, and then programs have started up, particularly into research and demonstration projects, and then gone away. But all of a sudden, things are really, really happening. And there are two reasons for this. The first is the advent of digital signaling technologies. Digital imaging and digital signaling has suddenly dramatically lowered the cost of actually getting information from one place to another. And because that cost is lowered, it's now economical to apply telemedicine to more and more applications where you wouldn't have been able to before. So the cost of doing this has really gone down. As a consequence of that, and as a consequence of the enormous increases in the amount of bandwidth or carrying capacity available, many companies, particularly carriers, telecommunication carriers and whatnot, are marketing telemedicine as an application for their services. And by the same token, a lot of consumers are looking for ways to take advantage of it. Thus, the financial incentives and the financial aspects of telemedicine are actually pointed in the right direction. And the second thing is that medicine itself has changed into a business. and may finally be willing to support the notion of providing services remotely if it's less expensive and more efficient to do so. Well, what are some of the implications of all this? This obviously has some implications. And there's really not nearly enough time to talk about all of them, but let's touch on a few of the important ones. The first is that in the past, medicine has grown from a cottage industry, where you literally went to a doctor's cottage if you wanted to receive care, to more of a factory kind of oriented industry. We don't call them factories, they're called managed care organizations or hospitals or whatever, but in fact, these organizations employ hundreds or thousands of providers who bring in patients, process them, and then send them out healthier. At least that's the idea. Telemedicine has the potential of turning healthcare into something that more resembles interstate or even international commerce in healthcare, and that's something brand new. There is always a little international commerce in healthcare. For example, when the Shah of Iran came to the United States for healthcare when he was sick. But this just takes it to a whole new level. There is a company named I think it's American Telemedicine International in Harvard, based in Boston anyway, that is actually has a lot of contracts to read X-rays from the Middle East. They read dozens and dozens and dozens of X-rays every week, all for cash. You should also note that, like any major change in a major industry, long-distance delivery has both favorable and unfavorable aspects to it. The favorable aspects are, for the first time, you might be able to see a doctor you wouldn't have had the financial means to go see in person. On the other side, you can possibly have some disruption in referral patterns, and some people who are currently doing business in healthcare may not be able to continue to do business in the same way. One example that comes to mind are so-called circuit riders. These are doctors who travel from town to town reading X-rays or seeing patients for a wide variety of problems. If most of the X-rays are now seen remotely, those people have to shift what they do. On the other side of that, you may now be able to have the best specialists in the world come right into your living room. So there's the trade-off. A second implication is that we have to decide if we want to spend our healthcare dollars on telemedicine and telecommunication services, and if so, how many of those dollars we want to spend on those applications, and under what circumstances. Healthcare anymore is sort of a zero-sum game. If you spend more money in one part of healthcare, it generally comes out of another part of healthcare. People are not able to tolerate or willing to support increasing the fraction of our gross national product that is devoted to healthcare. That means that if you increase funding for telemedicine, something else has to give. We have some trading off to do, is the bottom line there. We also may want to figure out if we need to realign our system of medical education to specifically train people to provide services remotely. And if that's the case, who trains them? I mean, who knows enough about this to train them? And furthermore, should they be certified with that kind of training? And what would the training consist of? And that sort of thing. As with any other tool that has economics incentives associated with its use, one also has to wonder whether telemedicine might be subject to abuse of some type. What if your local managed care provider or insurance plan determines that you're not entitled to in-person care unless you fail telemedicine care first, remote care? Or if you're not entitled to it because telemedicine care is more cheaply available and you're not sick enough or something like that. A final implication is that what's going on had better make people happier if it's going to succeed. Ogilvy, who is a marketing and advertising person, once observed that people don't really want cars, they want transportation. And in the case of healthcare, people don't really want healthcare. Nobody wants shots, nobody wants pills, nobody wants telemedicine. They want to feel better. And so if what we're doing with this technology does not make people feel better, we probably need to rethink our priorities in terms of investment and everything else. But this has ripple effects all throughout the medical care system. Everybody needs to feel better if this is going to work. For example, the primary care provider who refers a patient to a specialist wants certain things as well. And if he doesn't get it, or she doesn't get it, it's going to change the way things happen. I'll give you a quick example. Most primary care providers are really, really busy. In fact, in rural areas, they may work from 7 in the morning to 8 at night. And you're given the option as a primary care provider of seeing someone in person, and then if they need a specialist, just saying, tell you what, you need to go see a specialist, and they're out of your office and out of your hair. And they go off and drive however far it is to see that specialist. Alternatively, you're given the option of using a telemedicine system that, say, isn't located in your office. So now you have to leave your office, walk over to the telemedicine system with the patient, do the telemedicine consultation, which may take a half hour, walk back, and now instead of getting out at 8 o'clock at night, you're getting out at 9 o'clock at night. How long are you going to do that? Probably not very long. And so the way we implement this system is very important because it has a lot to do with whether the investment that we make is going to be successful. Where does Oregon stand? Before we go too far afield, we should probably see what's being done here at home. And although not really the most active in terms of the number of telemedicine programs that we have, Oregon's really very fortunate to have some real quality work being done here. And in my opinion, with its pioneering attitude and high-tech industrial base, Oregon is truly in a strong position to be a leader in the application of telemedicine technologies if it wants to be. I'm currently aware of 6 telemedicine-related programs underway at the present time in this state. The Eastern Oregon Health Services Consortium's RodeoNet program is recognized nationwide as a pioneer in the delivery of remote mental health services. And those are things like counseling services, pretrial hearings, commitment proceedings, that sort of thing. Follow-up visits, medication adjustments, all of that can be done remotely. In fact, with mental health, there's rarely anything that you really have to examine other than the person and the person's responses to interaction. Well, RodeoNet originally started out with a grant from the Federal Office of Rural Health Policy, but to give you an example of why Oregon is so special, it's one of the few programs that has actually gone to survive beyond the duration of its federal grant. And Kathy Britton, who's one of the primary coordinators of that program, is really pretty much a national resource when it comes to figuring out how to set up and maintain mental health programs. The second program I know of is the Central Oregon Network based at St. Charles Hospital in Bend, which started out about 4 years ago. This started out with a grant from the Murdoch Trust and currently serves Madras, Prineville, Redmond, John Day, Burns, Lakeview, Heppner, and Warm Springs with both teleradiology and electrocardiogram-based telecardiology services. The Northeastern Oregon Teleradiology Network is in the slow process of getting started in LeGrand and Enterprise, and initial funding there is being provided by the Rural Utilities Service. So you see, every time a program starts, it seems to start from a different source. This will be initially limited to teleradiology. Continuing medical education programs for rural areas are regularly coordinated by and broadcast from Oregon Health Sciences University. These are offered free of charge to physicians, nurses, and allied health personnel in 33 different sites throughout the state, although not all sites are frankly participating right now, and it's all done over a satellite-based system. Then finally, there are 2 programs that it's been my privilege to be associated with. The first is the Advanced Telemedicine Research Program at Oregon Health Sciences University. And the emphasis there is it's a comprehensive research program directed toward determining the most efficient and least expensive ways of providing teledermatology services in particular. So what we've done is taken a single chunk of this broad spectrum of telemedicine. Telemedicine is not one thing. It's a combination of teleradiology and telecardiology and teledermatology and tele-ENT and tele this and tele that. And it's important to recognize that because what works in one part of telemedicine may not work well in another part of telemedicine. In dermatology, we rarely need to see things move to make a diagnosis. On the other hand, for mental health, that's critical. So you might have different types of equipment for different types of programs. Our program is funded by the National Library of Medicine, and the emphasis there is to try to find out what's the least expensive, most efficient way to provide dermatology services in particular, and then what effect does the provision of those services have on the communities in which they're provided. And so it involves both pre-intervention and post-intervention data collection in an effort to try to figure out what did we do, what happened. And we're very privileged to be working with 3 wonderful communities, Hermiston, Lakeview, and Nissa, in this project. It's funded both by the National Library of Medicine and Oregon's health education centers, area health education centers. And then finally, the Oregon-based Telemedicine Research Center is an independent, nonprofit organization that's leading a nationwide consortium of telemedicine programs in the first multi-center collaborative program to evaluate the utility and effectiveness of telemedicine technologies. It's hard for me to describe to you what that means because it's so unique. The Telemedicine Research Center is trying to put together data from a lot of programs all over the country. Every one of these individual programs rarely sees enough patients, especially when it starts to be able to say something definitive about the utility of the service that you provide. But if you pool data from a lot of programs simultaneously, you can often get answers a lot better. In fact, this is done all the time in cancer studies and in HIV and AIDS research, because cancer, although cancer is very common, the patients are spread out all over the country. And if you were waiting in Portland to get enough cases of melanoma to decide if a treatment worked, you would be spending years waiting to get enough cases to make that determination. On the other hand, if you pool data from cancer centers all over the country, you can get the same results in a much shorter period of time. And the TRC is currently one of the prime contractors on a healthcare financing administration study to try to determine what telemedicine is worth. The Healthcare Financing Administration feels that's very important because you can't decide to pay for something unless you know what it's worth. Otherwise, you may be paying for more than it's worth. The TRC is primarily supported directly and indirectly by the Healthcare Financing Administration and the National Science Foundation. So where are the challenges here? It's a brand new field that's full of twists and turns. It's a huge field. If you can imagine taking all of medicine and duplicating it in an electronic ether, that's how big the field of telemedicine is. And in a sense, the way telemedicine relates to in-person healthcare is it's like 2 layers of a layer cake. If you take one layer and you take all of medicine, all of medical care provided, like dermatology and radiology and cardiology, they're all pieces of the cake. And there are certain things you can do and certain things you can't do in person with each of those specialties. For example, in person, you can't see somebody who's on the other end of the state. And so your ability to treat somebody in post-op for post-op follow-up checks on a regular basis, or to see what their wound looks like if they're running into trouble, is very limited. If the weather's bad, it's even more limited. So there's certain things you can't do in person because you just can't manage it. On the other hand, telemedicine is divided up into pieces as well. There's a dermatology piece to telemedicine, but there are certain things you can't do with telemedicine. You can't feel anybody right now. You can't see if they have swollen lymph nodes, for example. You can't see if a particular skin lesion is hard or soft. You have to have someone describe that to you. And so there's sort of like parallel parts of the same field. And where people feel threatened by telemedicine, where primary care providers feel threatened by telemedicine, it's because they see that one part of the cake might be disappearing without seeing that there's a whole nother part that you might be able to take advantage of. The challenges are myriad. There are quite a few challenges, actually. It's what I spend most of my time doing anymore is trying to figure out what they are and how to deal with them. The first being, can we do this right? There's plenty of room for error in dealing with the adoption and implementation of any new technology, and this is not really an exception to that. States such as Iowa have spent millions of dollars on telecommunications setups that essentially duplicate telecommunications setups that they already have. And other places spent millions of dollars on telemedicine systems that are terribly underutilized, and sometimes not for very good reasons. For example, the Medical College of Georgia implemented a system that cost $8 million and succeeded in seeing only 125 patients in its 3rd full year of operation. That's a lot of money. And to give you a perspective on how many patients that is, the average specialist would see 125 patients in 6 days. So when you consider the cost per patient seen for their system, with just the depreciation on the equipment alone, it's thousands and thousands of dollars. Was telemedicine a bad idea? No, telemedicine's not a bad idea. Was that implementation of telemedicine a bad idea? Well, you have to look at that. Above all, success in telemedicine requires that when you do stuff like that, you use your head as well as your heart in trying to figure out what to do and how to do it. And there's no substitute for good, insightful, clever planning in this part of human endeavor any more than any other part of human endeavor. The second challenge is that true research in this field is lagging behind where it should be. Despite the fact that we've had a lot of demonstration projects, exactly what those projects have demonstrated is pretty unclear in a lot of cases. There's been precious little evaluation that's been done, and especially where taxpayer dollars are involved, there has to be some way of determining whether any particular type of telemedicine investment is worth making, because you'd like to know if you want to make that investment again somewhere else. Another challenge is that laws, rules, and regulations regarding medical care, medical licensure, accreditation, and that sort of thing are not keeping up with advances in the delivery of care. And frequently, the current laws simply serve to maintain the status quo. That's not necessarily a good thing. Reimbursement policy is also in limbo, mostly because it's not clear what this is worth in many cases. Although for some cases, it is pretty clear. Medicaid, for example, health care services to the poor, is frequently reimbursed because they pay for travel. And so you can pretty much trade off easily your travel expense versus the expense of setting up and running a telemedicine program. It's pretty difficult, however, in real life to take the attitude, well, this life, a single life saved, is worth every $1 billion we put into it. And there's still an enormous lack of awareness on the part of healthcare providers and consumers alike about what telemedicine is, why it might be useful, and whether they should think about it at all. Unfortunately, the hype associated with things like telecommunications and computers doesn't really help, because people, after a while, their eyes glaze over. And it makes it difficult to get a lot of communication across about what it really means to you in your own personal life. There are a few good sources of information, however. The Telemedicine Research Center operates a comprehensive database of information on the World Wide Web. And for any of you who have web connections, the address there is http://tie.telemed.org. The Telemedicine Research Center could be reached at 503-221-1620 if you have any other questions. Dealing with this education problem is more challenging than you would think, because it's not clear who you ought to educate or how. In the first part of this century, when dial telephones were new, the telephone company brought them into schools when they wanted to introduce them into a particular community. The school children quickly learned to use them and brought the information home to teach their parents how the technology worked. True story, absolutely true story. And in the case of telemedicine, this approach probably continues to have some merit. In fact, the Telemedicine Research Center recently sponsored a set of Oregon high school ski races to begin to build awareness of telemedicine in our own Oregon high school graduate students, sort of trying to educate them right out of the gate, you might say. However, I would note that this is one area of human endeavor where we'll need to make all generations aware of what's going on and what it means to them, because what happens here really ends up mattering to all of us. While we care a great deal about our children's health, most illness occurs in older adults. And so it's very important to older adults. And all of us are going to become older adults at some point here. Telemedicine is a tool that has something to offer nearly everyone, but only if we choose to construct and wield it properly. With that, I'll close, and thank you very much for your attention. I'll be happy to answer any questions in the remaining few minutes.
Dr. Perednia, you alluded to the shortage of healthcare professionals in rural Oregon, and it seems as though one of the key areas of interest for Oregon is how could we use telemedicine to supplement what is available in those outlying and medically underserved areas. What I'm curious about is in your conversations and dealings with rural healthcare practitioners, those who are out there, is there a readiness and an eagerness for this? Are they kind of clamoring for telemedicine and seeing ways to integrate it into their practice? And secondarily, if there is that readiness, how capable are they and their patients of providing for these services?
It depends. It's really true. Actually, in our research project for teledermatology, we were turned down by half a dozen places easily. And the reason is, again, you're talking to primary care providers who are really busy. And the last thing you need is another headache, especially given the way medicine's going anymore. And so when presented with the idea that, gosh, we could use telephones and television and whatnot to help you in your practice, the usual reaction is, oh, right, yeah. However, there is some hope. We've now been up and running in 2 of our sites, one for 5 weeks and one for 3 weeks, and doing teledermatology applications, which are store and forward. Store and forward means that you gather all the information at one time using an electronic camera and getting history and that sort of thing, and then you transmit it and then forget about it, so that you don't have to do anything interactively, so it doesn't take as much time in general. And it's much easier to tolerate because a provider can say, I would like to get some images taken of this patient, please send them, okay? And then they're sent and they come to Oregon Health Sciences University or wherever, and you look at them. And in 5 weeks at one site and 3 weeks from another, we've had 15 consults, which is actually at an annualized rate makes us one of the busiest telemedicine programs in the world. And those consults have actually been, at least for us at Oregon Health Sciences University, really useful. We worked with one case that turned out to be a melanoma that none of us thought was a melanoma. But the specialist here didn't know what it was. And when you don't know what it is, you often biopsy it. And biopsy had not been really considered as the next thing to do. And lo and behold, it turned out to be a melanoma. And so the short answer to the question is providers are as ready as their knowledge about the field prepares them to be. And where all you know is about how difficult this can make your life and your practice, you're not enthusiastic at all. In terms of their ability to provide the information, in terms of the ability to use the information that comes back from the consultant, everybody can do that. And our sites actually have done an extraordinary job, I think, of collecting and relaying information, taking wonderful photographs and providing some really insightful history. So it depends, and I think it's going to get better over time, but only if we use our heads.
Doctor, one of the most interesting parts of your speech was your discussion about the necessity for some sort of economic analysis. I mean, discussing the trade-offs, whether it's the costs are worthwhile in particular situations. And of course, as we all know, we've kind of moved away from any sort of regulatory approach to making sort of capital and investment decisions in medicine. We're really moving towards a market approach, but the rural areas are the areas where market forces are often the weakest because there's often just a limited supply of providers in rather unusual situations. I wonder how you envisage the economic analysis is going to be done, that then place by place, about whether telemedicine is going to be worthwhile in a particular location.
That's an excellent question. Takes a lot. I think about that a lot. First of all, as with anything, you probably can't make as much of an investment in rural areas for the provision of healthcare as you make in urban areas. And the reason is that that investment is going to be averaged out over fewer lives or fewer cases. So just like you don't build a 500-bed hospital in Lakeview, you don't build a multi-million-dollar telemedicine system in Lakeview. The way you sort out what kind of telemedicine system to put together is try to figure out what are the needs of the community and what are the things that are really missing. I'll give you a really nice example that's going on a little bit in the Midwest, and that is that there are many places where it's very difficult to staff a community with an emergency room physician. There aren't all that many emergency room physicians, and the burnout rates in small rural communities are quite high. And so one thing they've done is they've taken healthcare providers who are not necessarily physicians, but who are physician assistants or nurse practitioners, and taught them as much as I can about emergency room skills and emergency room care, and then put in a telemedicine system that allows mentoring of those people. So that if they are faced with a situation where it feels like it's getting over their head, you can give them somebody else's insight into what it is might be going on at a lower cost than, say, bringing them out to the site or sending the patient. In terms of how you pay for that, it turns out that's a lot less expensive than hiring and keeping an emergency room physician. So that's money that you can use for something else. That whether it's upgrading your hospital or upgrading the diagnostic equipment or whatever. In terms of where it fits in the market, it pretty much depends on the way the economics are set up in any particular circumstance. If, for example, with the advent of managed care providers are told that they have to cover a certain area. Say, if you're going to provide services for people in Portland, you have to provide them for everybody in Oregon. You're then into a situation where the managed care provider is going to have to think about, okay, if I have to cover everyone in Oregon, what's the least expensive way to cover everyone in Oregon? And that's how the process of assessing and figuring out how to work with telemedicine gets started, by having to make resource allocation decisions about what you will do and what you won't do. And the nice thing about telemedicine in one way is that although you'd think that rural areas don't have many choices because there aren't many people, if you're going to, say, contract or provide dermatology services to a rural area, with telemedicine, there's no reason why those dermatology services have to be provided by someone in your state. If someone wants to aggregate the demand over all rural areas in this country and base a telemedicine system in North Dakota, they can do that just as effectively as providing the telemedicine services from 15 miles away or 20 miles away. So there are now become a lot of market dynamics that just weren't there before, where you can aggregate demand, you can perhaps have providers bid against one another nationally or internationally to provide services, and create whole new sets of relationships where you wouldn't have expected them before.
We have time for one more question.
I was very struck by your comment that this is now making medicine an international commercial endeavor, and I think that is going to have really important implications for a lot of things. What I'd like to know is a little bit about how the legal and the reimbursement aspects of that play out. I mean, certainly as a patient, it's suddenly potentially very attractive to me to get on my internet website at home and take a picture of my skin lesion and think that some physician in India might do a really inexpensive job of providing a diagnosis. And obviously there are fears about, no, but this is going to happen, folks. And one thing I have learned about the internet, having studied it quite a bit, is that jurisdictions become irrelevant. And so if you could talk a little bit more about both the legal obstacles to getting good care the way that you'd like to do it, and some of the legal fears that I'm sure you have of people doing exactly what I'm talking about.
First, what's your home page address?
HTTP:/BC and Bowling. No, seriously, I'm running the session next week on nonprofits and government internet things. Neil McBurnett. If
no, that's an excellent question. Very, very, very good question. Nobody knows is the short answer. There are, within the United States, there are legal kinds of things you have to worry about. For example, malpractice. However, in licensure and that sort of thing. However, there literally is nothing to prevent a physician in India from trying to diagnose and treat something over the internet and just having you pay via credit card. There's absolutely nothing to prevent that. And so issues of consumer education tend to be pretty important. How do you know you're getting what you're paying for? How do you know that the person on the other end is even a physician? How do you know that they're anything except the boiler room of doing consults remotely? And so those sorts of issues tend to be pretty important. Where that will sort out, I think, is that just as now there are places that we go that have a reputation for excellence and delivering good care at a reasonable price, or good services of any type at a reasonable price, the same thing will develop in the world of international and interstate health care. So there'll be people that you trust, and word will get around, and there will be reviews, and there will be, at least in the United States, probably ultimately licensure and accreditation that is done over state lines. The Association of State Boards of Medical Examiners actually presented a model act to their congregation that has been repeated in several states, where several states now prohibit doctors from out of state delivering teleconsultations to people in their state. I'm not sure that's really a great thing for the citizens of that state, to tell you the truth. And that will have to work itself out, probably initially in the manner of the Wild West, but ultimately we'll get a handle on it. That's the best I can do, I think.
Dr. Perednia, I want to thank you very much on behalf of everyone here, including those on the airwaves, for a very enlightening and interesting talk. I had a question I'm going to ask you right afterwards. When you were talking about the things you can do now, you said, but we can't feel that part of the person's body that may be in question, and you added a word, yet. I'd like to ask you about yet. Thank you all for being here. See you next week. This meeting is adjourned.
That's an excellent question. People are working on it, and there's a device actually that was invented by a graduate student where you put your fingers into this device, and the other end of the device is someplace else, and it will adjust the resistance to your fingers according to the pressure that's produced by squeezing the thing on the other side. So what it does is it measures resistance and says, well, I'm experiencing so much pressure when I press at this point, and